Please welcome Chris and Joe. Thank you.
Great, thanks very much, Brenda. It's a pleasure for Joe and myself to be here today. And thanks for joining us. Not advancing.
Should I press in the space bar?
Just trying to advance the slide. I'll just run through the objectives. Joe and I would like to share our experience implementing the self-measured blood pressure pilot program in our practice. Here we go. From the recruitment and onboarding of patients to the workflows that we have adopted to capture and respond to patients' home blood pressure reading. Just a word about Health-Centric Advisors, where I spend a half day a week and have for almost 20 years. Health-Centric Advisors is an organization that supports quality improvement and practice transformation to achieve the quadruple aim, which includes improved and provider experience, improvement of health status, and cost savings. They work with office practice providers, staff, as well as patients directly. Other areas they work in are hospitals, long-term care facilities, and home health. In particular, one of the focus areas for Health-Centric now in the physician office work is on remote monitoring, such as is used in this practice, and also we hope to extend to diabetes and heart failure. About this self-monitored blood pressure pilot program, Health-Centric was lucky enough to be awarded the only contract as a pilot from the Centers for Medicare and Medicaid Services. It is a pilot that is supposed to run just over 7 months, and it will end in the middle of February. The goal is to recruit 150 patients with uncontrolled hypertension, which we have, for the purposes of this program, defined as 140/90, which is really stage 2 hypertension at this point by the new guidelines, which Joe will review. We are aiming to include a very diverse population. Part of the program supplies at no cost all the enrolled patients with a no-cost Omron Series 10 wireless Bluetooth monitor. We will speak more about how it transmits data directly through an Omron app on a smartphone and delivers that to a database portal that we can see. Other elements are that it has alerts that are customizable. There is a substantial education component to this program. One of the websites at the end of the program will list all of those. There are also separate educational sessions for patients, and we're holding the first one, people that have been onboarded already. We're holding the first one tomorrow night, Wednesday, the 22nd, from 5 to 6:30 at Coastal Hillside in Pawtucket. Because this is a pilot program, CMS wants us to learn and them to learn from us what has worked well as we have done improvement cycles, and to present this to the rest of the country in the form of what is called a change package, or what you consider a template to launch this program in another practice. So the basic question this pilot program is asking is, will home blood pressure monitoring with electronic transmission directly to a provider result in more rapid control of blood pressure? Here's listed some of the partners that are involved in this blood pressure program. At this point, I'm going to turn it over to Joe.
All right, thank you, Dr. Campanile, and thank you, Health-Centric, for having me as a part of the webinar today. So the first thing that we want to touch base on here is, why would somebody think about implementing this kind of blood pressure program into your practice? So just some basic stats here. So you can see that about 1/3 of adult Americans, or 72 million adults, are thought to have hypertension at this time. And a clean half of those are those with hypertension which isn't under control. And then once again, 1/2 of those patients, or about 17 million people, are aware that they have hypertension. Their hypertension is being treated, but their blood pressure is still not under control. And that's really that target population where, well, why are those patients not being well controlled at this time? And I think there's many different factors which go into that. You know, we've all had those patients here in the practice who their blood pressure is above goal, but they tell us, oh, but my blood pressure is always at goal when I test it at home or at my local pharmacy. We're also going to have those patients who their blood pressure is above goal, but they, you know, kind of fight and plead and say, you know, give me some time for the lifestyle management, diet, exercise. Let me focus on that. And a lot of times we fall into the cadence of allowing that to continue. And maybe we see them again in 6 months and another 6 months, and we kind of continue that trend. All the while, more people are being diagnosed with hypertension as well, leading to this high number of people who know they have hypertension, it's being treated, but we're just not within those thresholds that we'd feel comfortable. So here's some more data to kind of talk about that. So you can see that high blood pressure was either a primary or contributing cause to the death of more than 400,000 Americans back in 2014, which is about 1,100 deaths per day. And then we can see the high cost that hypertension has on the healthcare system. So $48.6 billion per year, of course, an estimate, but we're thinking healthcare services. So think about all of those office visits where people are seen, you know, maybe several times to adjust medications, recheck their blood pressure. And, you know, oftentimes that's a 2-week visit, a 1-month visit, rather than their normal maybe 6-month follow-up type visits. Also, medications are going to contribute to that high cost. Not many hypertension medications that are very costly anymore at this time. A few brand name medications still available like Systolic and Adarbi, but even some of the generic hypertension meds, which aren't made by as many manufacturers, can be expensive. And then of course the missed days of work where maybe patients are coming in for those visits and missing time, taking a morning, taking an afternoon off from work, and that's going to lead to an increased cost as well. And then finally, this brings us to that new blood pressure guideline that Dr. Campanile referred to. Of course, we still say new. This is now from 2017, but we know that sometimes it takes us a little bit of time to bring in those new guidelines into our practice. And for the focus of our pilot that we're doing now, we are focusing on those people with a blood pressure of greater than 140/90, which you can see is listed as stage 2 in this schematic. We can see that stage 1 is that 130/139 and the 80/89 diastolic, which should still be considered above goal for the majority of patients at this time. And, you know, really trying to focus on getting people to less than 130/80 if we are medically managing them, based in large part on the SPRINT study, which came out before these guidelines were published, really pushing for those lower thresholds for hypertension management.
So why home blood pressure readings? Many people feel that the readings that we obtain in the office setting are not the blood pressure that people have for the majority of their lives. Blood pressure readings at home can act to define or get around what is called white coat hypertension when the blood pressure is higher in the office as opposed to when it's done outside the office. And also some number of people who have masked hypertension, meaning that their blood pressure is at an acceptable level when it's checked in the office, the physician office, but it is really higher when it's at home. Another real advantage to this is that the fact that patients will take their blood pressure readings multiple times over a given week, and the fact that they have more data continuously really adds to the accuracy of the numbers that they have obtained. And patients in this pilot have really shown us that they are committed to taking the time to check their blood pressure many times a week. I think when you have this kind of medication or blood pressure feedback, you can feel more confident about what the true blood pressure is, and you can titrate medications more accurately, avoiding under and over treatment. I think also the fact that patients are really initiating the measurement and transmission of their blood pressure readings just naturally engages them more, makes them want to learn about blood pressure and everything that can be done pharmacologically and in lifestyle, and makes them also more likely to be adherent to their medication regimen. So on to some of the gadgetry and technical aspects of this program. This is a picture of the Omron 10 blood pressure monitor. As I mentioned before, the funding from CMS in this pilot allows us to provide no-cost Omron monitors, which can run anywhere from $60, $80, up to $100 in a retail store. You can see a picture over on the upper right of a person who has the cuff on their arm, and then on the bottom right, you can see the smartphone that is would be sitting next to the Omron monitor and would be receiving wirelessly the readings from the Omron 10. And here's a picture of, again, the person at the top who's doing a reading, and this is the home screen of the Omron app. So it will list some blood pressures, and if you were to press the history button, you would see a screen that looks like this, which you can scroll down and see all the blood pressures here, and it will present it in a graphic manner. I have signed on also, not just as a provider, but as a patient in this program, so that I am able to be aware of exactly how things work from the patient's perspective. Joe is going to review the use of the portal where this is automatically downloaded. But I do want to mention that we have tremendous technical support and backup in the staff at HealthCentric, whose name is Brian Lose. So whenever there is a problem with this, whether it's local or whether it needs to be fed back to Omron, that gets done immediately. And new applications or updates to this system are being added on a weekly basis as we feel are needed.
All right, so what we're looking at now is the portal from the healthcare provider perspective. So what we have here is the homepage of the portal. You can see there's a few different patients listed here. Clearly a Beatles fan was involved in putting this together. So we have Paul, John, George, and Ringo. But we're looking at basically their home readings, their most recent home reading in this case. And some nice features of this homepage are that you can actually sort based on not just their name alphabetically, but also based off of maybe the highest systolic reading that is the most current. So you can maybe see those patients who are still running above goal. Same idea with the highest diastolic reading, you can sort in that way. And then in the opposite direction, if maybe somebody's being overtreated, you can sort by the lowest systolic or the lowest diastolic. You can also see that the patient's pulse is included here. Certainly very important for those patients where we're using a medication that might be affecting their heart rate as well. And you can sort by that as well. So if, for instance, we have some people on some beta blockers and we're worried that we might be pushing that heart rate a little too low, we can sort by that reading too. So now we're going to look specifically at a patient's page. Oh, 1, 2. So this is looking at just one patient, and when you click on basically their name, you'll get here. So this is all of the readings. You can see that they're not quite as they're not happening on quite a daily basis at this point, a little bit more sporadic. But this is a good way for us to now look at a patient's trends over the course of 2 weeks and see where their readings have been. And from here, we can also see any number that might be an alert reading as well. And this is what an alert would look like. So when patients trigger at greater than 160 over 100, that will send an alert out. And that will also send an alert to us via email, so we're able to get that data a little bit more quickly and be able to act on that when needed. You can go ahead. And now we can kind of see at the bottom of an alert type screen, we can then document the actions that we've taken. So in this case, you can see that a patient was called, they were seen in the office for a visit, and you know, the blood pressure was good at the visit, so no medication changes were made. In some cases, what we'll actually have in these actions is a call to the patient, which is pretty common, a medication change where we're increasing and or adding a medication to their regimen. Oftentimes, even for those patients who, you know, are testing their blood pressures at home, they've been at goal for the most part. We'll also send them messages through our medical record, really just encouraging them to keep up the good work with taking their medications and taking their blood pressure regularly. And in that case, we'll add that kind of action to this portal as well, really just to track how often we're talking with our patients and engaging with those patients. And finally, this is looking at a different way to set alerts for our patients. And you can see that 160 over 100 would be a high alert, 180 over 110 would be a critical alert. There's also a lower blood pressure threshold. So if people are running too low, we can see that too, and hopefully either determine why those low readings were happening or maybe back off of medications, as we've had to do for a few people, really depending on that patient as well. So you can set these alerts to your specific patient. So for instance, if it's somebody who is running rather high and we know that and we're actively working with them, maybe we could set their thresholds for alerts a little bit higher. So that way, number one, we're not getting emails around the clock, but number two, those patients aren't getting alarms when their blood pressures are still running high. And instead they can feel confident that we're just continuing to work with them on that. And then another thing that we can see that really helps to guide our medication decisions is an averages screen of the blood pressures. So we can see how patients have trended over the last 3 weeks, including this week. And we can really get a feel for not just a few readings, not just 1 week of readings, but really out to a month's worth of readings that can help us to understand how their blood pressures have been trending and really help to guide our decisions in terms of medication adjustments and the education that we provide to our patients.
So I'd like to go through some of the concrete steps that we implemented here in my practice a few months ago at Coastal Hillside to get this program going. So first is to identify one or more providers in a practice who are willing to participate in this. They feel like they have a number of patients and they've been seeing them for a while and the blood pressure is not at goal and they just need some extra kind of information or convincing of a patient. Identifying a team member to work with, in this case, a primary care provider, and in my case, it's Joe who's presenting with me today. Then you need to run a report of patients whose last blood pressure was at that greater than or equal to 140 over 90. So most electronic health records these days will allow you to put in filters such as a provider's patients, age over 18, and a blood pressure reading, and receive a list of patients, which I did. And I received probably a list of patients of maybe 80 or more. And then I went over the list to identify patients who would be appropriate candidates. One of the exceptions was having to have a smartphone. We now have a workaround on that where people can use the monitor and transmit their blood pressures to us either through an email or through the secure patient portal. Not quite as clean and hands-off as the model that transmits it automatically to a smartphone, but it's the next best thing. And there may be, I have a lot of patients that don't speak English. We're in the process now of expanding the program to be able to include Spanish-speaking patients. At that point, we sent out a letter to the patients that I felt were appropriate from my scrubbed patient list. And then waiting about 10 days after that, again, sent on my behalf, very important to do the communication on behalf of the patient's primary care provider, a letter just asking them if they received a letter in the mail and would they consider onboarding or becoming part of this program, answering any questions they would have. And at that point, it would be scheduling an onboarding session for the patients. I should say that as the program went on, I have onboarded or recruited more than a handful of patients just during a patient visit when, just like the scenario I was alluding to before, it's someone that I've been seeing for a while. Their blood pressures always run like 140, 142 over maybe 88, something like that. And the patient says, I know I can do more exercise or change things when they really have maxed out in the lifestyle category. And they either are reluctant to start medication or increase or add another medication. And at that point, I can say to them, you know, we have this program, you're going to have a high quality home blood pressure monitor. It's going to transmit things without you doing anything except hitting a button on an app on your phone. And then we're going to review these. You're going to do it often enough that we're going to have very solid blood pressures. And then we're going to review these and then make a decision. And at that point, the patient really enters into an agreement where they say, yes, you and I are going to look at these blood pressures. We both think they are believable, and I agree to act on them if my blood pressure truly is 140 over 90 or greater. So that has really resulted in people willing to take action and more rapid control of their hypertension. So the onboarding of patients is completed by the HealthCentric advisory staff. We try to make it as convenient as possible in terms of the day, the time of the day, the location. We have done them here at the conference room at Coastal Hillside. We have done them at other locations. Some patients have even gone to the HealthCentric location in the Foundry area in Providence. We try to make the sessions as concise and as short in time as possible, depending on the number of people. They can run 1 to 1.5 hours or maybe a little bit longer. During that time, people receive educational material on blood pressure and hypertension as a condition. They receive the monitor, and at that time it is paired to their smartphone, and they are then showed the recommended technique for taking blood pressure, which is shown on this slide, and they get to practice taking their blood pressure with their new Omron monitor, and thereby are able to learn how to do it and enter their first couple of readings. There is some data looking at the various aspects of this correct technique, and when they are not done, the fact that it can have a 10 to 15 millimeter variance in the blood pressure that is taken. I also think that it's easier. Remember, I do this in this program as a patient too, and I think it's easier at home to sit at your kitchen table and get your arm out on the table and really take a blood pressure with the right technique than it is in the office. And Joe is now going to talk about his role as a care team member.
So you can see here that we listed a few different potential care team members who could take part in this depending on the organizational structure. Of course, here in our office, it's a pharmacist, but in other offices, maybe that would be a nurse care manager or an office nurse. So we are lucky enough to have some support staff who's able to bring some of those blood pressure readings from the portal online into our medical record. From that point, I'm able to assess those values, I typically will go onto the portal and look for any kind of alert type values, as well as look at the weekly averages for patients, hoping to then summarize those findings, and then to kind of determine my course of action from there. For patients who maybe have blood pressures at goal, oftentimes I'm not even including Dr. Campanile at times, because I'll send a portal message to the patient. I'll say, you're doing great, and to keep up the good work. If for some reason there's something that stands out, whether it's a low reading, a high reading, or a trend of highs or lows, that's a time when I'm going to send a message over to Dr. Campanile. We're going to discuss what's been going on with the patient. I'll typically provide a couple different ideas for recommendations we could make, and then he'll send that message back to me, and then I'm doing the contact with the patients at that point. And really, you know, this is kind of a lot of the same in terms of the workflow here. But really, I think, you know, what we're able to do with contacting those patients and really making them feel engaged really keeps them on board with checking their blood pressures often and knowing that they've taken that active role in their health. In my interactions with these patients, they've been very open to the changes we've made, as well as continuing to test their blood pressures, and really feeling like they're taking an active role in their care through this.
So we're just going to present a few slides with some early data from the pilot, and these are the 25 patients who are from Coastal Hillside. The lion's share are patients of mine that I work on with a lot of assistance from Joe, as you just heard. So out of 25 patients, 60% or 15 of them have an average weekly blood pressure under 140/90. So remember, everyone started at least with a blood pressure of 140/90. And 68% of the patients have measured their blood pressure at least 3 times per week. There is a request in the beginning of the program to check the blood pressure a couple of times a day, and then more often during the week, and then settling into 3 times a week as sort of a maintenance phase. So I think that speaks to patients' real engagement and willingness to continue checking their blood pressures regularly. There are a couple of patients who have made very rapid progress in controlling their blood pressure, and 2 of them who have reached a blood pressure of less than 120/80 after just 3 weeks of participation. So once again, remember, these 2 people started with a blood pressure at least 140/90. So they dropped 20 in their systolic and 10 in their diastolic after just 3 weeks. Alerts for outlier readings that Joe mentioned that go out. There's been 11 medication changes documented. I think that really speaks to the action portion of this program. People are willing, after discussion with their provider or with Joe as their pharmacist, to make medication changes. And again, patient engagement, which is evidenced by patients on average, all 25 people, taking their blood pressure 6.4 times per week. And the next slide shows just a population trend of this group of 25 people who started out with blood pressures of 148/90 as an average group, and with a very steady and constant trend in a lowering direction, are now at 130/84 after 4 weeks of participation, which was earlier in the initiation of this program. So at this point, Joe and I just want to make a comment about the impact of this program on our existing responsibilities as a PCP and a practice pharmacist, and just to let you see or speak as to whether we are still as happy as we appear in the photos here that started out this presentation. I'll let Joe go first.
All right, thank you. So certainly as happy as we looked when we were taking the pictures, I think. So I think one area where the impact on my existing responsibility is really an increase in patient engagement. So I've had the ability to interact with patients that maybe I wouldn't have interacted with otherwise in managing their blood pressure as well as their hypertension medications. I've been able to increase the amount of engagement I've had with them also in terms of lifestyle education. So discussing with patients different things like the DASH diet as well as their, the exercise recommendations to really help them take that full approach to their blood pressure and really just kind of reinforcing the things that Dr. Campanile and our providers here have been probably trying to drill into them for many years, but always good to hear it from another voice. Another thing that I've seen is that I've had an increase in engagement with the providers I work with as well. Hypertension wasn't necessarily a disease state that we worked as closely in before, aside from, maybe somebody that was on already 3 or 4 medications and looking for a 5th agent, let's say. But instead, I'm getting involved in really the early on management of hypertension where maybe a patient's only taking a low dose of amlodipine to start, and I'm helping with that initial titration. So that way, hopefully, by the time they come in for their next visit, we're not still increasing that first medication, but maybe we've already gotten it to the goal dose and their blood pressure's at goal. And we can really streamline that next office visit to other things that might need to be focused on. And the other thing that I'm hoping to accomplish based on this program is some reduction in the amount of burden on my providers. So really helping to streamline this process, provide as much data as possible upfront, make a recommendation, and really make this as easy as possible for them as well, and hopefully making their office visits with these patients easy too.
Thanks, Joe. So I'd like to start off just by saying, as I have always said, that the 2 factors that I think are involved in the improvement of the healthcare delivery system is health information technology and teamwork. And I think this program's success to date highlights the importance of both of these, with the hands-off electronic transmission of blood pressure values through a smartphone app to a portal database, along with the collaboration of team members that are receiving the information in real time and working together to implement needed changes in the care of their patient in a timely manner. You can see the amount of work that Joe does involved in the care of my patients, and he has my confidence and the competence to be doing that, to be sending me messages on patients that need some additional medications, and he has the competence as a PharmD to also make suggestions, which are usually the ones that I take him up on. This is the type of program that I want more of. It draws on our expertise, requires minimal time and labor, and brings significant improvement in patient health in a relatively short period of time. And to me, this is the type of program that combats the threat to our healthcare workforce, AKA clinician burnout. So Joe and I would love for you to experience the same satisfaction that we have with this by signing on as a provider in this program. I hope we don't sound desperate, but I hear tell of a $150 gift card for a provider that has the largest number of patients recruited to Al Forno restaurant. So that's something to keep in mind. We are going to put up a slide with, while we're taking questions, if there are any, that has contact information to Brenda Jenkins, and also a website that has a load of educational resources, both for patients and for providers and for training. So at this point, we would like to take questions, and we'll put up the contact information now. I don't know if there are any questions.
Maybe do. Hi, this is Brenda. If you do have any questions, please add them into the chat. We did have a question here. Did any medication changes involve changing the timing of when patients take specific blood pressure medications? And if so, what classes and at what times?
Yeah, so this is Joe. I can probably speak to that. So one common thing we do run across, especially with blood pressure medications, is a common adverse effect of feeling dizzy, especially after taking their blood pressure medications. So oftentimes one of my counseling points is to maybe change the timing of their medication to bedtime to, number one, hopefully avoid some adverse effects. But there is also some data to suggest that taking some of the different blood pressure medication classes in the evening might actually be more effective in managing blood pressure. So one of those classes of meds that at times I'll recommend taking in the evening is the calcium channel blockers. Another class of medications where I'll commonly recommend taking in the evening is if we're using a beta blocker to manage somebody's hypertension, where that might also cause some fatigue to the patient. So there have been a few times where I've made that type of recommendation to change the timing to hopefully alleviate some adverse effects, but maybe even to achieve some better blood pressure control as well.
Yeah, I would second that. And as Joe alluded to, there was a recent study where they looked at time of day and blood pressure control, and over time, some further endpoints for blood pressure as a risk factor for cardiovascular disease. And I also think that there can be increased adherence if people can just take their medications, sitting on the kitchen table counter or in the bathroom at night, and they're less likely to miss if it's just once a day, those medications. I just might make another comment about one of the options that a practice has. It's very customizable. Some practices have wanted to change the actual levels of blood pressures for the alerts that they receive, or even what time of day and what days that they receive the alerts. So providers like myself have the option to have access to the portal or not. So I have access to the portal. I want it. I receive emails, and in my Coastal email, when there is an alert, and what I do is just log into the portal and look over. I have 25 or 6 patients in there right now, and I can quickly look over the highs and lows, especially like Joe said, you can order the systolic and the diastolic and the pulse from high to low just by clicking on the top of the column. And then I can go into their chart and I can do something, or oftentimes I will message Joe and start a discussion about what we can do. But the point is that we saw something, and it didn't wait until 3 or 4 weeks or 2 months until we saw the patient again to do something. We were able to address it right then and contact the patient through the portal if possible, and if needed, with a phone call if they don't have a portal or there's more complicated instructions to deliver.
This is the next question. It was about a smartphone. So the next question we had was, what if patients didn't have a smartphone? Were they excluded? So I believe initially that was part of our inclusion criteria for this, was requiring that smartphone for the Bluetooth connection to the Omron 10, and kind of that seamless blood pressure readings coming directly to us. As Dr. Campanile referred to before, there is a workaround on that where they can still have the monitor at home. They would simply have to then transmit those readings to us, maybe through the patient portal, which we have in our medical record. But not having a smartphone was something where we were excluding that to start. Next question here is from Chris. He said that was the mean blood pressure reduction calculated either among the 60% of responders or all study participants? And I believe the answer for that is that the blood pressure reductions that we were referring to in those slides with the statistics was specifically looking at the 25 of the Hillside patients that we've been tracking. That number has actually increased even within the last week. I believe we have 28 patients now at the Hillside practice, but that was among those 25 patients that data is referring to.
And at this point, we have just about 75 patients in the entire program, and our goal is to have 150. And though the program pilot was originally slated to end on February 16th, there has been a request to CMS to have a 90-day extension because we feel like it's running well and the onboarding process has been improved, and we want to have time to be able to recruit that other 75 patients.
Okay, the next question here is, I'm wondering if you've had success with the program with patients who are not already on meds. And I believe it's another thing we referred to earlier, but maybe it's that patient with the blood pressure of 142/88 who, as Dr. Campanile mentioned, has maximized their different lifestyle modifications that they might be able to do, is still really hesitant to consider starting blood pressure medications. Maybe they feel their blood pressures truly do run at a better number at home, and then we're able to track those numbers at home and hopefully begin medications in that case. So we do have a couple patients who would fit into that category where their blood pressure has been slightly above goal in the office. We saw those numbers continue to track that way with their home readings, and now we've been able to start medication therapy based on those home readings, even after they were initially hesitant when they were here at the office. Now that they saw that their home readings truly were above goal, we were able to, continue that discussion through my conversation with them of the importance of having their blood pressure be managed to those lower goals that we discussed, and then initiate therapy and continue the follow-up from there.
Yeah, and I would add, I think the patient education part of this program is really key. We certainly, Joe and I, when we have face-to-face visits with patients, try to provide education, but that's just in the context of a visit that has limited time. And I think if you can show people both we have in the onboarding process and also in the 90-minute program that will be tomorrow night, if you can show people some data that they'll understand that their goal for a lot of people, a lot of my patients, my goal is to never take a medication in my life. And if you can switch that goal in their life to, my goal is to not have a heart attack or a stroke because I have high blood pressure, because they now appreciate the connection. I think that that bit of information, once they've internalized it, will make them feel like, okay, I'm ready to take some medication because I don't care about the medication I take. I care about what my blood pressure is.
So our next question here is, how are you confirming that the blood pressure monitors are accurate during the onboarding process? Is there a calibration that is done? I actually don't know the answer to that.
Yeah, I believe there is a calibration that's done. Maybe someone else who, I'm not involved in the onboarding, but I understand that there is a lot of supporting data for the Omron 10 itself. But in terms of the calibration, I don't know if anyone else, Brenda or Brian or Allison, anyone knows that. I can't say that. For me, I encourage people to bring in their monitors because I like to look at the history, and I like to take a blood pressure with their monitor and with me, the sphygmomanometer and my stethoscope in the room, and compare them. And if there's any significant variation, then I would question the veracity of the Omron blood pressure monitors. But I don't know if anyone else on the team can speak to the initial calibration of the monitor. Okay. Okay.
Okay, I'll take it. This is Allison from HealthCentric Advisors. The cuffs that we use, the Omron Series 10, they are validated. As far as the calibration, we don't do the calibration part. It's an automatic calibration that happens with the cuff. We found that the first initial reading tends to be a little higher than the other ones, and part of that could be you have 4 or 5 people staring at you in the room. But even some documentation from Omron has stated that the first 1 or 2 might be higher, but we do suggest to each patient to bring their cuff with them to their next visit and go through the process that Chris was just explaining.
So if there are no more questions, again, the contact information in the name of Brenda Jenkins at HealthCentric Advisors is up, and then the other one is a website that has resources. So I would encourage people to think about signing on to this program, generating a patient list of people that would be appropriate for it. And if you have other questions, please, you can send them to Brenda and she will pass them on to Joe and myself at Coastal, and we would be glad to message you back. So I think if there's nothing else, then we'll close out this webinar. Thanks very much for attending.
I believe there will be a evaluation link being sent out afterwards. I'm not sure if it was put in the chat at the moment. So if you don't see one, we will be emailing all of the participants.
Very much. Awesome. Okay.
Thank you everyone for your time, and thank you again to Chris and Joe for presenting for us. And this has been recorded and we will be sharing at a later date. Thank you again for taking the time to chat with us during your lunch hour, and we'll see you next time.